Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in Easy Endo Prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. Today we are talking about prediabetes. According to the 2026 ACE Consensus Statement, prediabetes is defined as an A1C between 5.7% and 6.4%, a fasting glucose between 100 and 125 milligrams per deciliter, or a 2-hour glucose value between 140 and 199 milligrams per deciliter during an oral glucose tolerance test. When I look at the ACE algorithm, I think it can be simplified into a very straightforward clinical pathway. First, remember the goals. We want to prevent type 2 diabetes, reduce cardiovascular risk, promote meaningful weight loss when appropriate, and improve quality of life. Everything begins with lifestyle intervention. Every patient, regardless of weight, should receive counseling on nutrition, regular physical activity, resistance training, adequate sleep, smoking cessation when applicable, and long-term healthy habits that can realistically be sustained. Lifestyle therapy is not the backup plan. It is the foundation upon which everything else is built. The next step is to address cardiovascular risk. Prediabetes is not just about glucose. It is also about blood pressure, lipids, liver health, and future cardiovascular disease. Every patient should have aggressive attention paid to these risk factors because reducing cardiovascular risk is just as important as preventing diabetes. At this point, the algorithm asks one key question. Is the patient overweight or obese? If the answer is yes, then weight loss becomes the central therapeutic target. ACE recommends aiming for more than 7 to 10% weight reduction because that degree of weight loss has been shown to substantially reduce progression to type 2 diabetes. Once you've identified excess weight, look for associated complications that may help guide therapy. If the patient has established atherosclerotic cardiovascular disease or steatotic liver disease, semaglutide may be particularly attractive. If the patient has moderate to severe obstructive sleep apnea, tirzepatide becomes an important consideration. If no comorbidities, we can consider incretin-based therapy or phentermine with topiramate extended release. For selected patients with severe obesity or significant obesity-related complications, metabolic or bariatric surgery should also be considered. Now let's go down the other side of the algorithm. What if the patient has prediabetes but is not overweight? Lean prediabetes should prompt a broader differential diagnosis. Rather than assuming routine insulin resistance, consider whether the patient may have early autoimmune diabetes, latent autoimmune diabetes in adults, monogenic diabetes, pancreatic disease, or another secondary cause of dysglycemia. In appropriate patients, antibody testing and additional evaluation may be warranted. Sometimes the most important clue is not the glucose value itself, but the fact that the patient doesn't fit the usual phenotype. Regardless of body weight, some patients remain at particularly high risk for progression to diabetes. For those individuals, ACE notes that 3 oral medications have evidence supporting delay of progression to type 2 diabetes: metformin, pioglitazone, and acarbose. None currently carries a formal indication specifically for diabetes prevention, but all have supporting clinical data and may be considered in carefully selected patients. The final step is reassessment. If dysglycemia persists, but the patient has not yet crossed the threshold into diabetes, continue intensive lifestyle intervention, ongoing weight management, and aggressive cardiovascular risk reduction. If overt diabetes develops, transition to the type 2 diabetes treatment algorithms. The major pearl from this entire guideline is that prediabetes should not be viewed as a harmless waiting room before diabetes arrives. It is an active cardiometabolic disease state that deserves attention today, not years from now. And one final pearl before we close. The highest risk phenotype is the patient who has both impaired fasting glucose and impaired glucose tolerance. Those patients are much more likely to progress to type 2 diabetes and deserve particularly aggressive intervention. When you see prediabetes in clinic, don't focus solely on glucose. Look at the entire cardiometabolic picture: body weight, blood pressure, lipids, liver health, and overall cardiovascular risk. And in lean patients, think beyond insulin resistance. Prediabetes is not simply an abnormal lab value. It is an opportunity to change the patient's future. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.